Good evening, everybody. Thank you for joining us for this lecture on airway equipment. So let's quickly go into the activity for today. Last week, we learned about airway assessment, but today we'll be learning about the equipment that we use in airway management. The next week, we'll go into difficult airway management. So a quick quiz for all of us. Which airway device is most appropriate for a patient with facial trauma and suspected cervical spine injury? If you know it, you can put it in the chat box. Anybody? Let's be quick so we don't waste too much time. Hey, somebody said C. All right, excellent. So, which of the following is true about the eye gel airway? It requires cough inflation after insertion. It is not suitable for spontaneous breathing. It has a gastric access port. It cannot be used in cardiac arrest. Any answers? Okay, somebody said C again. Very correct. All right, so let's look at a case of difficult airway. So a 58-year-old male is brought to the emergency department after a motor vehicle collision. He's unconscious with a GCS of 6. He has visible facial trauma, bleeding from the nose and the mouth, and he was stridulous. His oxygen saturation was 85% on a non-rebreather mask. Attempts at bag mask valve ventilation were unsuccessful due to poor mask seal. An oropharyngeal airway is placed, but ventilation remains inadequate. So the team decides to secure with a definitive airway. So the question is, which of the following is the most appropriate next step in managing the patient's airway? Insert a nasopharyngeal airway and continue bag mask valve ventilation. Attempt endotracheal intubation using direct laryngoscopy. Perform a surgical cricothyrotomy. Insert a laryngeal mask airway as a bridge to intubation. Attempt fiber optic nasal intubation. So what do you think? Any answers? Somebody said C, insert a laryngeal mask as a bridge to intubation. Any other answers? C again. Wow. So this patient has a GCS of 6, has visible facial trauma, is bleeding from the nose and mouth, and is stridulous, and saturation is 85%. Somebody else said, attempt fiber optic nasal intubation. And finally, somebody said, attempt endotracheal intubation using direct laryngoscopy. Then somebody said C, perform a surgical cricothyrotomy. It would have been nice to do like a count or a survey and then see how many answers carry the vote. Okay, so the correct answer is C. And let's see why that is. So if you do a nasopharyngeal air, put in a nasopharyngeal airway, it's contraindicated because there's facial trauma with nasal bleeding and there's risk of intracranial insertion in this patient. Also, if you do a direct laryngoscopy, it may fail because the mouth is filled with blood, there's distorted anatomy, and there's limited visibility. However, a cricothyrotomy is indicated because this is a cannot ventilate, cannot intubate scenario with facial trauma and stridor, indicating a compromise in the patency of the airway. Of course, with the bleeding and all, there's also high risk of aspiration. So LMAs are useful but may not be effective in severe facial trauma, and they do not secure against aspiration or provide definitive airway control. A fiber optic nasal intubation is also contraindicated in facial trauma and would likely fail due to the bleeding. Okay, so what are our learning outcomes today? We classify, at the end of this lecture, you should be able to classify airway equipment, discuss their indications, contraindications, and complications, describe the design and use of this airway equipment, and discuss some innovations in some of them, and of course, explain the importance of the difficult airway trolley. So Joseph Clover's nasopharyngeal airway was the first to be seen that we can date back in history in 1870, and that's the and then Sir Frederick Hewitt's oropharyngeal airway in 1808. And the first supraglottic airway device that we all know, as we all know, the precursor to all the innovations we have in supraglottic airway devices, was first developed by Archie Brain in 1980. And the pharyngeal bulb gasway was developed in 1937. The Macintosh laryngoscope that we all are used to, which is the first equipment we know how to use in advanced airway management, was first introduced in 1943. However, since all these firsts, there's been a widespread use of supraglottic airway devices and their innovations, and a lot of video-assisted devices, particularly in the last 2 decades. These tools that are available to clinicians have dramatically improved safety and effectiveness in airway management. However, despite these advancements, the global disparity in access to advanced airway equipment remains a serious concern in low and medium income countries. So a survey done by Nwaso et al. In 2014 revealed that only a few individuals have access to training with novel airway techniques like the fiber optic bronchoscope. They reported that even though 51% had the fiber optic bronchoscope, only 22% were conversant with its use. The availability of recommended airway equipment and airway management training was reported to be suboptimal by Adesiyan and Nohoma in 2016 in a survey done in Nigeria. Then a global survey conducted by the WFSA in 2021 revealed that greater than 40% of LMICs reported an inconsistent or no access to video laryngoscopes, and that greater than 30% lacked basic airway devices in emergency settings. A survey carried out by the Society of Specialists in Airway Management in 2022 in Nigeria revealed that 52% were confident using the supraglottic airway device. All 50 respondents to this survey had video laryngoscopes in their institutions, but only 22% were confident in using it. 42% had fiber optic bronchoscope, but only 4% were confident in its use. 24% were confident in attempting a front of neck access, while 40% had never attended an airway workshop. So the shortages in this, the availability of this recommended and very important advanced airway equipment and advanced airway equipment, and the lack of training, particularly the lack of training, can lead to preventable complications, increased morbidity, and even mortality, particularly in difficult airway scenarios. So we can classify this airway equipment that we're talking about based by the airway management purpose it's used for, if it's invasive or not, the anatomical location of the equipment, the airway access route, and by the function. So going by that, we can then say by airway management purpose, if it's a basic airway device or an advanced basic airway device, an advanced airway device, you have the oropharyngeal airway, nasopharyngeal, and face masks, and some other adjuncts and oxygen delivery devices under basic airway management devices. Then for the advanced, we have the endotracheal tube, the supraglottic airway devices, the video laryngoscope, and the cricotyrotomy, if you think along the lines of the plan A, plan B, plan C. Then we also have the invasiveness, which they could be non-invasive, basically the basic airway management devices, and then invasive being those that are infraglottic devices. Then we also have the anatomical location. They could be supraglottic or infraglottic. And then for airway access routes, could go through the oral route, the nasal route, or a surgical route. And for function, they could either be ventilatory devices, visualization devices, or airway adjuncts. So for basic airway management equipment, we have, like I said, they are mostly non-invasive, and they are the face mask of different types, the oropharyngeal airway and the nasopharyngeal airway. They are usually introduced through the oral or nasal routes, and a lot of them are airway adjuncts as well, and they are used in oxygen delivery, and some of them actually could also be used in ventilation. So I won't go too in-depth into it. I just wanted to remind us about the oxygen delivery devices, which could range from the nasal cannulae with outlined here at the flow of oxygen that gives, and the percentage of oxygen that is delivered to the patient at the different flows. And then we have the simple face mask, the face mask with reservoir bag, the non-rebreather, and the venturi mask, the face tents, and high flow nasal cannulae. So for the venturi mask, you don't need to cram the colors because they are color coded, and they deliver at the different oxygen, the rates of oxygen delivery, the percentage of oxygen that is delivered. This is particularly important in patients who have chronic obstructive pulmonary disease. So the others here also, nasal cannula, giving us some details and why they are important. For the nasal cannula, it's important. You can use it. You start with this. If the patient does okay, you don't need to go further, because oxygen also has its own disadvantages and complications. So you want to use as minimal as required to achieve your purpose. So it can be extended use, can cause a lot of drying if it's used without a humidifier. It's important that you use it with a humidifier. And a simple face mask also can be used to deliver up to 60% oxygen. The lateral perforations permit exhaled CO2 to escape, and you can also use it with the humidification devices. So the non-rebreather face mask, if both flaps are removed, the percentage of oxygen that can be achieved, it does 80 to 85%. If at 10 to 15 liters, it can even give you up to 800%. If one flap is removed, it increases the FiO2. If both flaps are in place, you can get up to 100%. And of course, the venturi mask and how much oxygen concentration is delivered. So the face mask, from history, we can see that the earliest ones were Schimmelbusch mask and Yanka masks, as seen in the diagrams above there. And they allow administration of gases to patients from a breathing system without introducing any apparatus to the patient's mouth. The modern face masks are made up of black rubber, clear plastic, elastometric material. And all of them consist of the body, the seal, and the connector to the breathing circuit. So there are variations in this face mask, and one of them is the RBS, Rendell Baker Sussex mask that is used in children of less than 10 years. It's triangular in shape and has less dead space. It can be used also in tracheostomized patients. That's the diagram up there. Then we have particularly the endoscopic mask that has a port or a diaphragm for the allow fiber optic the fibroscope insertion. Then particularly in children, we have sainted mask that improves their tolerance of those face masks when they are inducing them. So this mask provide a soft seal that fits over the patient's nose and mouth and permits non-invasive positive pressure ventilation and allows effective administration for up to 100% oxygen. So the breathing system is usually attached to the mask via a catheter mount and at a 90-degree angle piece. This angle piece attaches the mask via a standard 22-millimeter connector, and the mask is designed to seal the face using either an inflatable cushion or a silicone seal. Pediatric masks have a pleasant scent, like I said, to improve their acceptance. So what are the advantages? The sealing face mask allows 100% oxygen to be delivered. The face mask is the simplest method of applying positive pressure ventilation. Its use is an essential component when managing respiratory or airway emergencies. That's where we start from. It requires less anesthetic bed than if you are using it for delivery of anesthetic gases than tracheal intubation, tracheal tube or supraglottic airway device. Now, no need for muscle relaxants and lower incidence of sore throat with the use of this device. However, achieving a seal may prove difficult, like we learned last week. There are some anatomical issues that might make the seal difficult to apply or maintain. So particularly in patients with no teeth, some patients experience claustrophobia, a significant problem. It can be a significant problem, but it has been improved by modern transparent masks. Anesthesiologist's hands are tied up. You can't do other things when you have to hold the face mask to the face of the patient. And higher fresh gas flows are often required. There can be gastric insufflation, especially if the ventilatory pressures exceed 20 cm of water. Aspiration and regurgitation of gastric contents can occur, and often more episodes of oxygen desaturation may require more oxygen. Okay. So safety is to avoid its use in non-invasive positive pressure ventilation, because if you use it for prolonged use in that, the pressure injuries may occur, the skin may break down, and then there can be injury to the facial or trigeminal nerve. So the Goodell airway or our oropharyngeal airway are usually used interchangeably to describe the airway adjunct designed by the American anesthesiologist Arthur Goodell. It extends from the lips to the pharynx, fitting both the tongue and posterior pharyngeal wall. Indications include in unconscious patients to improve upper airway patency and protect the tongue from biting down, from being bitten by the patient themselves. Anesthesia can be used for anesthesia before insertion of or after removal of a definitive airway. It's used in emergencies by health professionals who don't have advanced airway skills. It's used to prevent patient from biting or occluding the endotracheal tube. And it also can be used to facilitate suctioning and to obtain a better mask fit. So this is a picture of it, and you can see that it has a flange to limit depth insertion. It's color-coded with a range of sizes. It's reinforced to prevent biting down on it. And then the latex free biological inert polymer is used in its design, and its tapered edges to reduce oropharyngeal mucosal trauma on insertion. the rigid kinked resistance cuff to push the tongue forward and keep epiglottis off the posterior pharyngeal wall. So the appropriate size can be determined with the hard-to-hard method or soft-to-soft method. If you are using the hard-to-hard method, the flange is placed at the level of the incisors and the tip at the angle of the mandible. If the soft method is from the angle of the mouth to the tragus of the air. So in adults, the gluteal airway is usually inserted upside down and then rotated 180 degrees once it has reached the back of the oropharynx. So that's a picture depicting what I just said. So the advantages include that it's simple, easy to use. It's available in most, let me not say all, because I know that there are some places where it's not available in low and medium income countries. It's easy to use, it's available in most places, and healthcare professionals, most healthcare professionals are familiar with its use. The advantages are that it's poorly tolerated by semi-conscious patients and may induce vomiting. Blind insertion may cause bleeding, especially upper airway tumors if they have within the airway. Incorrect sizing may cause obstruction. So if it's too long, it may push the epiglottis over the laryngeal inlet, or if it's too short, it might pass the base of the tongue. Complications, trauma to the airway structures, oral airway structures. It can also cause hyperactivity. Airway hyperactivity can cause ulceration or necrosis to oropharyngeal central structures and dental injury. So for the sizing, I think we've spoken about that. There are variations in this airway. One of it is Waters airway, where the metallic hollow of the oropharyngeal airway has two holes at the pharyngeal end for attachment of oxygen line and suction. It's cheap and it's reusable. We also have the Sapphire airway. It's S-shaped, as seen in the diagram here. It's S-shaped, and it consists of two Goodell-type airways soldered together. And we also have the Copper, which is the cuffed oropharyngeal airway. It's also a modification of the Goodell airway. It has incorporated in it an inflatable cuff to seal the oropharynx and an integral bite block, and also a 15 connector for attachment of the breathing circuit. Then the Patel Syracuse endoscopic airway is designed to aid fiber optic intubation. It has a central groove on the lingual surface for passage of the fibroscope. The Bowman intubating airway has a tubular, is tubular along its entire length and open on one side. It can be split and removed from around a tracheal tube. So they can be used as an oral airway or as an aid for fiber optic or blind or tracheal intubation. So this over-sapien airway also is also an intubating oropharyngeal airway. It's also designed in a way to aid intubation. The Williams airway intubator is designed, this is that here, for a blind tracheal intubation and can also be used for fiber optic intubation as an oral airway. The proximal half is cylindrical and the distal half is open at the lingual surface. And we have the nasopharyngeal airway. I think we are all conversant with this. It extends from the nose to the pharynx to below the base of the tongue above the epiglottis. It's less stimulating than the oropharyngeal airway, but in cases of oropharyngeal trauma, a nasal airway is often preferable to an oral airway. So the variations of that include the Linda nasopharyngeal airway, so a plastic with large flange and flat distal part is supplied with an introducer with a balloon at its tip. So it provides better sealing. We also have the cuff nasopharyngeal airway that comes with a cuff that is inflatable, and then it can also be attached to a breathing circuit there. Then the basal airway, the binasal airway, consists of two nasal airways joined together by an adapter for attachment of breathing system and can be used to administer anesthesia. So what are the indications? Tongue obstruction, inadequate oral opening, or oral surgery. It's well tolerated, even in conscious patients. The sizes are 8 to 9 in adults, and in the small adults, 6 to 8 millimeters. For contraindications, if there's any issue with coagulation or suspected basilar skull fracture, you avoid it. And this picture depicts how it is inserted. So let's have a quick quiz. The patient shown in this diagram is a 6-year-old with a plunging ranula scheduled for resection. The 3 attempts at endotracheal intubation resulted in bleeding and all were unsuccessful. Following the difficult airway algorithm, the practitioners attempted to insert a supraglottic airway device. Remember, now the patient, there's blood in the airway. All of these attempts were also unsuccessful. So why do you think the supraglottic airway insertion was successful? Anybody? Why do you think it was unsuccessful? Anybody want to try?
I think because of the presence of edema also.
Okay, so because of the tumor, the attempts at inserting the supraglottic airway device was unsuccessful. If you remember last week, we had a mnemonic for the reasons why a supraglottic airway device might not be, so insertion might not be successful or might be difficult. So there was restricted. Yes, the plunging ranula blocked the airway. So restricted mouth opening, obstruction, which this ranula is providing, a distorted airway, then stiff lungs or C-spine with the Rod's mnemonic. Now, my second question is, what other airway equipment could have been helpful? Anyone? In planning to intubate, it was an elective case. What do you think they could have done to achieve a better outcome? Anyone?
I could have done a tracheostomy.
Okay, they could have done a tracheostomy ab initio. Remember, this is a small child, and it's not so long a procedure, and you're not expecting there to be difficult extubation or airway obstruction after they remove this ranula. So they might not really favor it, but it's an option that they could have taken. Somebody said VL. Yes, I agree with you. I think they could have used a VL ab initio from the get-go. That might have improved the view for them and probably giving them a better Comac and line, and subsequently they could have used a bougie. What other thing could they have done? Any other person? So if they can motivate this child as well, if it's going to be very difficult for this kind of child, if they ended up intubating him, it would be good. But if they didn't and they had to wake him up, then subsequently they might need to plan, even though it's very difficult in a child, an awake fiber optic intubation. Okay. All right, let's go on. So advanced airway equipment, they are invasive supraglottic devices or infraglottic devices. They can be surgical, root cricothyrotomy, tracheostomy, and then visualization devices like direct laryngoscope, a video laryngoscope, or fiber optic scope. So most of them, like I said, this is just an array of the different types that we are going to be discussing. So supraglottic airway devices are placed over the glottic opening, and they are capable of acting as a passageway for ventilation, oxygenation, administration of anesthetic gases. They come in different shapes, different designs. So the temporary management of the airway can be used for that, and it's inserted via the mouth, and they do not penetrate the pharynx. So this is a depiction of the different types, the LMA unique, the classic LMA, the ProSeal, that comes with a double tube, then the Supreme LMA, laryngeal tube, the iGel, AirQ, the Combi tube, and then, as it says, it's a combination of tubes, the intubating or fast-track LMA. So what are the clinical uses of this equipment? So it can be used for elective ventilation. You can plan to use if it's adaptable for the surgery, fasted patient, no intra-abdominal collection or possible risk of gastric regurgitation and aspiration. You can use it for elective ventilation or very short procedures. In cases where you encounter a difficult airway, like in that patient, if there was no contraindication to its use or risk of difficult insertion, you could use it within the difficult airway algorithm or your plan. You could also use it even as a conduit for difficult intubation in combination techniques. When there's a difficult mouth opening, you must have at least 2 finger breaths to be able to insert it. When there's limited head and neck movement, like I said, in combination techniques, you can use it with the fiber optic bronchoscope, endotracheal tubes, and other adjuncts. So when there's a cardiac arrest, it's particularly indicated in out-of-hospital cardiac arrest because it's been found that it's easier, the learning to put it is much easier than learning how to do an endotracheal intubation. So it can be a conduit, like we said earlier, for intubation and pre-hospital airway management, and also for pediatric anesthesia practice. So what are the contraindications? Risk of aspiration, local irritation when you already have airway edema, because the pressures that you need to use are higher, and it can cause further trauma. Upper airway trauma, when there's pressure-induced lesions or nerve pulses can result. Obstruction, laryngospasm, and then positive pressure ventilation. When that is your original plan, you don't want to use that ab initio. When there's pulmonary edema or bronchoconstriction or long duration surgeries. So this is the design. You have the basic design of most of them. This is the classic LMA design that has been modified and a lot of innovations applied. So basically there's a tube, airway tube, there's the mask, and then a cuff and the aperture. And then some of them do not have this pilot balloon of cuffs. They just have the mask. Then you have an indication balloon and the inflation line, and then the connector to the breathing circuit. This is a rough table showing us. You don't need to cram it because when you look at the device itself, it has markings and it tells you the exact size in terms of the weight of the patient and the cuff that is required as a range, as a rough estimate. Okay, so you can classify, classifications have been done by Cook into generations, and then Miller into whether they have other criteria for their classification. So we're looking at the different generations now. In recent, before they used to say Baska, Elisha, and 3GLM were 3rd generation. However, there are others that have been added to that group now, and these are somewhat considered as 2nd generation by some literature. Here as well, the 1st generation are the classic fast track, soft seal, short seal, LMA unique, the slipper, the ambu oral. We are going to see all those, but with time as you use this, you will know the different classifications. So the 1st generation are just basically airway tubes that do not have any port for gastric to reduce gastric aspiration, or even a well-designed mask to maintain a better seal on the laryngeal inlet. By the time you get to the second generation, you then start having improvement by insertion of gastric ports that you can use to deflate the stomach and ensure a less risk of regurgitation and aspiration of gastric contents. Then you can also classify if they are cuffed or non-cuffed. So all are cuffed except the eye gel, the Basca, the slipper, and the 3G LM. Then for suction ports, by the time insertion, if they have suction ports, if the suction ports are channeled or non-channeled, they can also be classified accordingly. So this is another, sorry. Okay, so this is another classification. Can you see it? Okay, good. So based on the sealing mechanism of the mask, for the first generation, they have an inflatable cuff, and the cuff is perilaryngeal. So for the classic LMA or the Pro Seal. Then the Pro Seal has an added advantage of having a draining channel. Then for the base, if the sealing mechanism is at the base of the tongue, an example of that is the combi tube, which also comes with a draining channel. And the second generation have pre-shaped cuffs or sealing mechanism within their cuffs. And this we have in the eye gel, which also has incorporated draining channel, and a device can be used as a conduit for blind intubation. Then the slipper has also an incorporated draining channel, but its pre-shaped cuff mask is at the base of the tongue. Then the third generation have a self-energizing mask or sealing mechanism. What that means, it adjusts to the pressure within the oropharyngeal structures. So it's dynamic and self-energizing. Okay. Sorry. My slides seem not to be moving. Okay, so the supraglottic airway devices, there's also another diagram that shows us the airway tube for the first generation. Like I said, is only the airway tube. By the time you have the second generation, then you have the additional design features like I had described, which include to reduce the risk of aspiration, higher seal pressures to enable controlled ventilation at higher pressures, integral bite plug to protect the patient's airway against occlusion. So this is also just another way of helping us to remember. So for the older devices, they can be first generation or second generation, and the newer devices as well can be first generation or second generation. Sorry. Wow.
I think I went off
briefly.
briefly. I'll start again.
What's happening?
Can you hear me?
We can hear you, but we can't see your slide anymore.
Yes, I'm going to come back. I think my internet sort of went off a bit. Just a minute, sir.
Okay.
Sorry, my My laptop is quite slow tonight. I don't know why. Sorry. So sorry. Okay. So, ooh, okay, let me just, can you still see my screen?
Yeah, we can see your slide now.
Okay, so, all right. Sorry about that. Let me try and get back to where I was. Okay, good. Okay, so I think we've spoken about most of the LMAs. It has gone beyond. I've pressed it beyond now. Okay. Let me just wait for it to land, then I would go back. Okay, so basically, we've spoke about most of them. I'll just bring our attention to some innovations. I know most of us have these devices, so I'd like to ask, what LMAs do you have in your institution? Anybody? What LMAs? Supraglottic airway devices do you have in your institutions that you use regularly? Anybody? So while you write that, I'll just go on and say most of us have just the classic LMA, and some have the iGel or the LMA unique. But a lot of us don't have the flexible type that is has the wires or metallic device included to make it flexible, and you can use it in some abnormal positioning. Then, of course, the intubating LMA that requires specific types of tube and that can be used as a conduit in difficult airway situations for intubation. Then the LMA Supreme that has a biplug and also has a place for a gastric port that's incorporated. Then the LMA Procil is actually two tubes incorporated, one for the gastric outlet, and you can see at the distal end there how you can then aspirate gastric contents. This is a better picture of the intubating of fast track LMA. It usually comes with LMA fast track endotracheal tubes. You can't use the regular tubes most times for intubating. Otherwise, you need to use a smaller tube to be able to achieve intubation. Then the other supraglottic airway devices that you can pass blindly, the combi tube that has an esophageal tube and then the tracheal tube, and you can You can then inflate them separately, or the king laryngeal tube that has one inflating cuff but double cuffs to seal off. You can also pass it blindly to seal off either the trachea or the esophagus. When it sits there, you can see with the distal cuff, inflation in the esophagus isolates the laryngopharynx from the esophagus. Then inflating the proximal cuff, inflation at the base of the tongue isolates the laryngopharynx from the oropharynx and nasopharynx. So I'd like to talk about the air gel. This is particularly one device that I like, basically for the advantages, which include the integrated gastric drain and the bite plug. So when the patient bites on it, it doesn't destroy the device. The simple insertion, you don't need your mouth to go into the patient's mouth to insert it. You just simply push it in, and the moment you encounter a resistance, you stop and then check. Then the cuff, there's no cuff to inflate, so it doesn't add time or manipulations. It's very easy. The moment the tube is in, then the next thing is to confirm. There's improved stability in dead loss patients. However, one major advantage that it's bulky during oral surgery, so it makes oral surgery impossible, and lower pharyngeal and esophageal seal pressures are lower compared to the LMA Pro seal. So these are other types that I know a lot of us might not have seen before: the sleeper, which sits there, the cobra perilaryngeal airway, and then, of course, the Basca, which is believed to be a third generation, and the 3G LM. Like I said, the seals here are dynamic and they respond to the airway pressures for the patient, so you can achieve a better seal and more higher pressures can be applied. However, the innovations now include this third generation Safe LM McGill, which incorporates a camera tube, an airway connector, the gastric port, the ventilation barrel, and inflatable cuff. You can see this can have a remote viewing, and this also you can see just like our regular VL that a lot of us have. You can directly see it, and it's been proven to improve success in airway management, especially when you use it for the combination techniques. So this is a diagram just summarizing the different types of supraglottic airway devices, the location of their seal, if it's perilaryngeal or at the base of the tongue, the sealing mechanism, if it's the cuff or a pre-shaped mask or a self-energizing mask, and then if it provides aspiration protection, if you can use it, reuse it, or if it's a single use. And as you can see here, that the only one that is not reusable here is the LMA Pro Seal and the classic LMA. Then if there's a conduit for intubation, it also assesses here. So many of them, that's the intubating LMA, the Cobra perilaryngeal airway, and then, of course, the iGel. So this is also telling us if we can, it allows us to have an endoscopic intubation. If you can do gastric, if you can use it for pediatrics. And finally, also the position and type of the dual lumen. If it's supraglottic, inflatable cuff, all the other design to improve its effectiveness in airway management. So what are the things that pathologies that can interfere with optimal supraglottic airway placement? These can be extraglottic, glottic pathologies, and subglottic pathologies. So you can look at that on your own. Let's not waste time. So these videos I have placed to help us learn about insertion and removal of some types of the laryngeal supraglottic airway devices. So when these devices are appropriately placed, the LMA tip rests over the upper esophageal sphincter, the cuff sides lie over the piriform fossae, and the cough's upper border rests against the base of the tongue. Such positioning allows for effective ventilation and minimal inflation of the stomach. So this is comparing the LMA and the endotracheal tube. Why do we need to do endotracheal intubation? Why not just LMA for everything? We've spoken about it. However, we can see that you always have to remember that no matter how good the LMA is, it's not a definitive airway. So what are the advantages of LMA over IT? There's increased speed and ease of placement, lesser hemodynamic disturbance. There's minimal increase in intraocular or intracranial pressure, no need for muscle relaxant. Disadvantages: improper placement, laryngospasm, obstruction, leak, dislodgement, especially in pediatrics, regurgitation, bleeding if there's trauma, complications with positive pressure ventilation, and lingual nerve damage. So what are the tips that we can help ourselves? Choose the right device and size. Weight-based size guides on the packaging of the LMA. Pre-use checks inspect for defects in the device, and insertion technique and position. Morning siphoning position unless it's contraindicated. Use a smooth and continuous motion. Do not force the device. Advance until resistance is felt. If it is not well sitting, then you remove and replace, or you do some manipulations in the positioning of the patient. Then troubleshoot if ventilation is not adequate, is inadequate. You position the head and neck, remove and reinsert the device. You must ensure that cough inflation is correct and not overinflated. You should beware of limitations, the limitations of this device, that they do not protect 100% against aspiration, even if they have gastric boards. So the most important takeaway for this aspect is that you must practice and be familiar with the device you have in your department. You can train with mannequins and during supervised procedures. So laryngoscopes, these are devices that are used to visualize the larynx and adjacent structures, mainly for inserting a tube into the tracheobronchial tree. So it uses insertion of the nasogastric tube, also can be done with it, or tracheoesophageal echocardiac probe. It can also be used for foreign body removal, upper airway lesion biopsy, or visualizing and assessing the upper airway, like the vocal cords and larynx. So there are different types, as we've outlined. They can be rigid, direct, indirect rigid, which use fiber optics and mirrors and prisms. Then we can have our video laryngoscope, can be rigid or flexible, optical stylets, and flexible fiber optic endoscopes. So we all know about our regular Macintosh laryngoscope. So I'm going to just go straight to the ones that we are not so conversant with. So there's the improved vision Macintosh blade. The mid portion of the tongue is concave to allow greater visualization of the larynx. The oxyport or MacPort Macintosh AA is a conventional Macintosh blade with a tube added right there under it. I'm sure some of us have seen some in our departments with a tube that you can deliver oxygen with. Then the other types of blades are the tool that is a modification of the Macintosh. It has a suction port near the tip there, and the suction channel extends to the handle and has a finger-controlled valve so that the suction can be controlled by the laryngoscopist. Then the polio blade, which has an obtuse angle to allow intubation in patients with iron lung respirators or body jackets, patients with obesity or breast hypertrophy, patients with kyphosis with severe barrel chest deformity, or patients with short neck and restricted neck mobility. The Bazari-Guifrida blade is a modified Macintosh made to limit the damage to the teeth. So the blade is useful for patients with limited mouth opening, prominent incisors, and receding mandible, short and thick neck on the anterior or an anterior larynx. And the flexible blade, like we usually call it the McCoy blade, It helps to improve the chances of successful intubation by a lever there that you can control with your hand right on near the handle of the laryngoscope to lift up the epiglottis in cases of difficult intubation. So there's less force applied, unlike in your Macintosh, and less stress response also results. So for our video laryngoscopes, they can be classified according to if they have an integrated channel. If, like I said, video, you can consider that the video stylet is also a laryngoscope of some sort because it goes to view the larynx. Then the rigid blade laryngoscopes, which can have a standard blade or an angled blade for difficult airway scenarios. So for the integrated channel, the airway or the blade, the channel can be integrated within the airway or within the blade. So when you talk about channel, it's just that opening there, that slit there through which you can direct your endotracheal tube. So the video laryngoscope, there's one called the Bullard. It's difficult, particularly invented for difficult intubation, especially those with limited head and neck movement. And it has incorporated oxygen port, fiber optic source, the stylet, for something for the stylet for the tube, and then the eyepiece. So these are older versions of the VL, and it's particularly good in patients with Treacher Collins and Pierre-Robinson syndrome. Okay, so the video Macintosh are these versions of the video laryngoscopes that have the Macintosh blade. It provides a better view than the original traditional Macintosh that are direct laryngoscopes. Then the glidoscope has a blade of 60-degree bend at the midpoint. So it's available in adult and pediatric sizes. There's less cervical movement than the Macintosh blade. So what are the complications that can arise from the use of laryngoscopy? Of course, it can damage all the oropharyngeal structures. Cervical spine injury can occur or TMG dislocation. There could be swallowing or aspiration of foreign body, for example, aspiration of the contents, maybe vomiting, or if you damage any of the teeth, this can be easily swallowed. The laryngoscope can malfunction, and definitely the things we don't like the hemodynamic changes, increase in heart rate and blood pressure. Now, the flexible bronchoscope is a device that has come to stay, and from our surveys, we've seen that many hospitals, at least in Nigeria, have them now. So it's a skill that we should all learn how to use, a skill we should all acquire, how to use the flexible bronchoscope. So it also has single-use versions. This is basically the design. It comes in pediatric and adult sizes. And most of this can have a remote, like you can see, screen for teaching. So even people who are not near the airway can easily see it. So it is a very useful tool. And these are some of the views that you can see on your screen of the different views that you can see on your screen. Now, the fiber optic endoscope relies on total internal reflection to transmit light, and it brings an image back from the tip of the flexible insertion cord. The tip can be angled to steer the scope. So that tip that we saw in this tip can be angled up or down. It can be manipulated and directed in the course of viewing the airway until you find you can enter into the laryngeal inlet and have a good view, and then railroad your tube over it. So, so the image may be viewed on an eyepiece or transmitted onto a screen. So the uses are for awake intubation, particularly in patients with difficult airway. It can be used in combination techniques. For example, the supraglottic airway guided flexible fiber optic bronchoscopic intubation, like we see in this diagram here. You can see that the LMA is already mounted and in, then the tube is mounted on the fiber optic bronchoscope, flexible bronchoscope, and then it's then introduced through the LMA and threaded. And the moment they enter the larynx, then the tube is railroaded over the bronchoscope and also eventually through the LMA into the larynx. So it helps to check positions of the endotracheal tubes for placement of bronchial blockers. You can use it to guide a percutaneous tracheostomy because some of them come with a light that can be seen on the anterior neck surface to guide tracheostomy. It can be used for suctioning and pulmonary toileting and diagnosis of upper airway pathology. So the advantages that it permits visualization beyond the glottis. It may facilitate intubation.
Adesiyan, you have 2 minutes, 2 to 3 minutes.
Okay.
I'm sorry for
all right.
you short.
I'll be done. Yes, I'll be done. So, so those are the disadvantages. So I'd just like to talk about the high flow nasal cannula oxygenation device. The advantage, this device can be compared to alternative methods of bag mask ventilation. It can stay in the patient. It's a device that can be stay in the patient and provide continued oxygen therapy. Provides positive pressure while during apneic periods compared to the bag mask ventilation and non-invasive positive pressure ventilation, prolonging the time that you have for oxygenating while the patient is apneic. So you can look at that later on your own. In adults, it can be titrated from 20 to 20 liters per minute to up to 60 liters per minute using specialized nasal cannulae. So like the flow rate, fraction of inspired oxygen can also be titrated as well. So you can give from 21 to 100%. So I have to run through this. We all know about our normal endotracheal tube and the markings and what they stand for. These are the requirements of an ideal endotracheal tube. And the types of tubes can be classified according to the cuff design, high flow volume, high volume, low pressure. So the cuff over a wide area of mucosa and the pressure exerted varies during the respiratory cycle. The low volume produces a seal over a low volume, high pressure, produces a seal over the smaller area. So they tend to exert a high pressure on the mucosa, reducing capillary blood flow and then potentially causing ischemia to the larynx. So the tube size and length can be calculated. The depth of insertion, we all know about that. Practical tips are that if you are using a cuff tube in pediatrics, the size should be 0.5 millimeters less than the cuffed tubes. And you can compare with the diameter of the smaller finger. Traditional, it's quick. However, it should not replace your normal calculations that you do based on the age and the weight. So particularly in pediatrics, please deflate your cuffs completely. If you are in doubt, do not delay in repeating laryngoscopy. Confirm and reconfirm. Always address airway monitoring alarms. Okay, so for verification, you can do that with auscultation, condensation fogging, capnography monitoring, chest x-ray. But now I'd like to bring our attention to using POCUS, the hyperechoic comet tail artifacts with posterior shadowing in the trachea. So the esophageal, if it's esophageal, there will be presence of a second airway adjacent to the midline of the trachea. And that is called the double tract sign. So it's a simple and accurate and non-invasive and fast method for confirming pediatric or even endotracheal in tube placement, and is found to be comparable to the gold standard of capnography. So it's highly, the sensitivity and the specificity is 100%. So additional checks should be done when you're transporting or repositioning your patients. And you can also do arterial blood gases to assess the patient's oxygenation. Then ventilatory settings, you adjust ventilatory settings based on patient's weight and all to ensure that everything is, the setting is appropriate for the patient. So the other special tubes, I just brought some here, like the cold tube used in pediatrics for neonatal resuscitation, the armored tube for abnormal positioning and maxillofacial surgery, neurosurgery, or shoulder surgery. Disadvantage is the moment it cannot be cut, and the moment it's beaten on, there's obstruction can occur. Then, of course, our south-facing and north-facing tubes that are particularly important in some kinds of surgeries. Yeah. So the north-facing uses a maxillofacial or dental surgery, and it's an alternative to tracheostomy or respiratory weaning. So the other special tubes are the microlaryngeal tracheal tube and tubes with extra lumen like the double lumen or those used for gas sampling and jet ventilation. The laser tubes, the laser shield 2 is designed for use with CO2 and KTP lasers, but its cuff is not laser resistant. So you still need a proper laser tube if you want to do laser surgery. So these are the indications and the advantages of using an endotracheal tube. And the disadvantages and complications that can arise. Here I've just brought out some airway adjuncts for us. Some are video. This video stylet is, as you can see, you can use it for intubation by mounting the tube on it and just going straight. You don't even need an endotracheal tube. The bougies, the tube exchangers, and the intubating canal. The different stylets, hyperangulated glide scope that is particularly useful for the VL. When you are using VL, these other stylets will not be very advantageous. You might not be able to thread your tube through the laryngeal unit. So this is particularly suited for that. The surgical airway devices come in different hospitals, and there are different kits that have been made available. And depending on what you have in your institution, you should get conversant with them. But we always, in the Society for Airway Management, advocate this simple tool that is available to everybody within Africa now. Your size 10 blade, the bougie, and then the size 6 endotracheal tube to quickly do a front of neck access. So the difficult airway trolley is just a device or a trolley that is used to ensure that all your airway equipment are stored in a logical fashion to have easy access to it and to ensure that it's always available in case you have a difficult airway. So it's a 4-drawer trolley that goes along the algorithm of plan A, plan B, plan C, and plan D. So these are just the equipment that you will see for plan A in the first drawer, the plan B, second drawer, and this is a design of different things you can use. However, in Africa, any trolley that has 4 drawers can be used if you don't have this available, and you can label them accordingly. So plan C, plan D. So in summary, a sound knowledge of basic and advanced airway devices is essential. More devices are not always better, because when you have too many things to choose from, that's, like we said last week, that's my distort, give you cognitive overload and maybe counterproductive. So what is important is you know what you have, you know how to use what you have. There's no point having an equipment that you don't know how to use. So you have to ensure that you train yourself. You have simulation sessions. You provide guidelines and departmental protocols for the use of this equipment and also the care of this airway equipment. Innovation and technology is not a substitute for basic clinical skills. You must always have your skills honed once and again. These are my references. Thank you very much. Murakoze, merci, shukran. Yalu, Ashanti, Nagode. I invite you again to the conference that will be holding in June 25th to 28th. Please join us to learn more about airway management. Thank you.
Thank you very much, Dr. Adesiyan. Please, can we just give her a warm round of applause for a very beautiful, well-detailed lecture she has given us today. Thank you very much, everyone. Our time is fast spent. Apologies for shooting above 1 hour. There were some technical issues, but I just hope that all of us have been able to get one or two things from the presentation. If our registrar is here, I would like to hear a word or two from her before we allow our consultant and seniors to say one or two things. Dr. Mashaba, are you still here?
Yes, I am.
Please say something. They would like to hear from you all the time.
Yeah. So thank you very much for the presentation. It was very comprehensive. I just want to find out about the laryngeal mask. What would be the cause for resistance on insertion? And if one is using a double lumen, so to speak, a double lumen laryngeal mask, you may need to guide us on what you do with the other port when you have connected the breathing circuit. What are you supposed to do with the other port? Or should it not be used for maintenance of anesthesia?
Okay, thank you very much, Ma. So if I get your question well, what will cause resistance? So if you have, for example, a tumor within the oropharynx, that could cause a resistance. If the patient is not well relaxed and the patient is struggling, they could be fighting you. Or, for example, if the patient is not well positioned, like in the money sniffing position, that will not cause resistance, but it might cause you not to, their position of the tube to the laryngeal ligament might not be adequate. And of course, if the patient already has increased airway resistance, ab initio, like there's edema, there's bronchospasm, all those things will not allow ventilation to be adequate. You will pass it, but you will notice that you can't ventilate the patient with the laryngeal supraglottic airway device. Now, for the double lumen, when I say double lumen, what I mean is the laryngeal mask that has two tubes. For example, let me just go for our ProSeal. So one is a gastric port, while the other is used for ventilation. So when you apply that, for example, if you look at, some have them for the ProSeal, it's separate. So when you are ventilating the seal, if the distal seal goes into the stomach, so it does not impede on your ventilation, while the tracheal tube opposes to the laryngeal inlet if it's properly placed. So that seals all your ventilation right into the larynx, while the distal tube, the opening at the tip, goes into the gastric, where you can suction whatever it is that is in the stomach. So you don't need to attach anything. You can just do your suctioning. When you're done with your suctioning, you leave it. But your circuit is attached to the tracheal tube that goes straight and is very opposed to the larynx. I hope I've been able to answer your question.
Yes, thank you very much. I just wanted us to be clear there.
Okay.
Because we don't want to take it for granted.
Yes, ma'am.
Thank
Yes.
you. Thank you.
Yes. Apologies, it's quite a voluminous presentation. However, I think apart from the recording, it will be good to provide the residents with the slides so they can take their time to digest the content.
All right, we'll make that available on the WhatsApp group. I hope everybody here is on the tutorial WhatsApp group. Professor Wanzo, are you still here, ma'am? Okay, I saw Professor Wanzo earlier on. Any other consultant would like to appreciate you. Thank you for joining us in training our next generation of specialists. Would like to say thank you and have a very wonderful good night and weekend. Thank you. See you again next week, everyone.
See you. Thank you.
Thank you, Prof.